All right, we're going to finish up our musculoskeletal course by talking about fractures and some of the common issues you see with these patients. So first, we want to be clear about the difference between a strain, a sprain, and a fracture. A strain is an overstretched muscle, while a sprain is an overstretched ligament. That's really the only difference between the two. Neither one involves any damage to the bone. Now, for strains and sprains, we simply use the RICE method. RICE stands for rest, ice, compression, and elevation. So we want them to rest. We want them to put their leg up if it's their foot. We want to wrap it with an ACE bandage and put ice on it, and that will take care of that. That will heal that over a few days. As far as a fracture, that happens when enough force is applied to the bone to actually crack it or break it. Now, you may or may not see an obvious deformity or bruising around the area, but it's also possible that a fracture could displace enough to put pressure on blood vessels or nerves. So we always want to check circulation and sensation distal to the injury. And then we want to know what happened. We want to ask the patient about the mechanism of injury because that helps us understand what type of fracture to expect. Now let's briefly review the types of fractures. A fracture is either closed or open. If the skin is intact, then it's closed. If it pierces the skin, it's open, also called a compound fracture. Okay. Transverse cuts the bone straight across. Spiral comes from a twisting force. This is actually very common in abuse, where someone will grab someone's arm, that person will try to pull away, and you'll have this twisting force that causes spiral fractures. So this is kind of a classic sign of that. Comminuted fractures is when you have little pieces of bone within the fracture between the two main pieces. This usually comes from some sort of crush injury. An impacted fracture is actually where the two ends of the bone push into each other because of like a vertical impact, like jumping off of a building. Now, green stick fractures is when it doesn't fracture all the way through. And what happens is this happens in children when their bones are still a little bit softer and more flexible. And it's like it bends, but it only splinters on one side and doesn't actually crack all the way through, just like a stick would. And then an oblique fracture is one that is diagonal or vertical or asymmetrical. So oblique fractures are one of the most likely to displace. So you can see how not only has this person's ulna completely dislocated, but they have this oblique fracture of their radius. And so that means that it's no longer aligned, it's displaced, and it can actually cut off blood vessels or nerves in this area. And so it's really, really important that we reset this bone into place and to be in alignment again before we do anything else. So they can do that manually, or they may have to take the patient to surgery to realign it and insert screws to hold it in place. Now, we use plaster casts like this one to help align and mobilize fractures. This allows for proper and straight healing of the bone. I'm sure you or a friend or a family member or somebody you know has had one of these at some point in your life, and I'm sure someone has signed your cast. So I'll go ahead and sign this guy's purple cast. Yay. So when your patients do have a cast, they could have swelling underneath the cast that can cause a lot of problems. So we want to assess for swelling, assess for pain, assess for circulation and sensation distal. So in the case of this gentleman, we want to make sure his toes are pink and warm. We can sometimes feel a pulse in the top of the big toe. So we want to check for that as well. But circulation sensation, we want to make sure he can feel it the same on this side as this side, because if this swelling increases so much, it can actually cut off blood supply. So make sure you're checking that. Another method that we use to align and immobilize fractures is called traction. This is where we pull on the leg or the arm away from the body to force it into alignment and to force it to be immobilized. So there's two main types of traction that we use. Buck's traction is where we apply a splint and we apply the traction force to the splint itself and pull that away from the body. That pulls the extremity as well. Or we can use skeletal traction, which is where we insert this big rod, this big pin through the bone, and then we apply the force to the pin itself. So we see this one a lot with femur and hip fractures because of the force required for traction. So essentially, this is the patient's bed. Here's a good bed, right? And this is the patient's foot. and this is their leg, right? We're going to insert the pin through their bone, and then we're going to attach it to this pulley. So we'll have a device on the end of the bed, and this force will attach to the pulley, and then you'll have a weight hanging off the bed. So this weight is my traction force, and it's going to pull the leg outward away from the body so I can align and immobilize that fracture. Now, the orthopedic doctor decides how much weight is required. So the big thing that you just need to know is that the weights need to hang freely off the bed. You shouldn't let them hit the floor. You shouldn't pick them up. As nurses, we are not allowed to remove the weights without a provider order, but we need to consider that we still have to do patient care, right? So sometimes if let's say we're moving the patient up in the bed, we'll have somebody just support the weight up. If you're traveling or transporting, you want somebody supporting the weight so that it doesn't swing, and make sure the provider knows if you need the weights off for some reason, and they will come and do that. But all we need to know is they should hang freely and they shouldn't be swinging. Now, we just want to review really quickly a couple of more severe complications of fractures. The first is fat embolism. Now, this is a risk with any patient who has had a long bone fracture. Essentially, when you have a long bone fracture, it cuts through the bone marrow cavity. And so this fat can move from the bone marrow into the bloodstream. And then just like any other embolus, which is something that moves around in the blood, it can go to the lungs, the heart, or the brain. Most often we see it the lungs. And so it presents similar to a pulmonary embolism. They're going to get restless and tachypnic. They may even have this impending sense of doom. And so it's very important that we support their hemodynamics, because unfortunately, there's really no treatment for a fat embolism. For a blood clot, we can give blood thinners, we can give thrombolytics, but for a fat embolism, we just need to support their hemodynamics while the body works to dissolve that fat. And then we can give corticosteroids to help decrease some of those symptoms. Eventually, like I said, the body will dissolve that fat embolus. The second major risk with fractures is called compartment syndrome. As with any injury, there's going to be an inflammatory response and swelling at the area. So if this is the patient's bone and this is the muscle around the bone, as this swells around this area, it can cause increased pressure in this muscle compartment. Okay, so increased pressure within the compartment. The problem with that is I also have a blood vessel in here. So as I put pressure on this, I'm going to collapse that blood vessel, and I'm going to cut off circulation distal to that area of swelling. Things you might see, patient's leg or arm extremity might be pale. You may actually see some blistering because of the increased pressure forcing fluid outward. And you may see a loss of pulse and sensation distal to the area. This is an emergency because they have the risk of losing that limb. So we need emergent intervention so we can prevent loss of limb. The main intervention for compartment syndrome is called a fasciotomy. It helps relieve pressure within that cavity. So a fasciotomy is when the surgeon literally takes a scalpel and cuts through the skin, through the fascia, and to or even through the muscle. That allows that pressure to be relieved so circulation can be restored. Now, we want to leave these open for as long as it takes for the swelling to go down. Once that swelling goes down, we could either close up the wound with staples or sutures like you see here, or we could leave it open if the swelling doesn't go down far enough. And we could use a skin graft. And you can see this patient has a skin graft over this fasciotomy site, just like with a burn. Now, this should be pretty obvious to you by now with everything we've talked about, but the priority nursing concepts for a patient with a fracture is mobility, or specifically alignment and immobility of the fracture, perfusion because of the risk for impaired circulation distal to the injury, and of course, comfort because we want to address any pain that the patient has. So just to recap quickly, fractures occur when a significant force is applied to the bone and causes it to break. We want to make sure the bone gets realigned because displaced bones can cut off blood supply or even nerves. So they have to be aligned properly to heal. We want to immobilize them for proper healing because if they're shifting around, the more they shift, the longer it's going to take for it to heal. And then we want to prioritize circulation and keep an eye on risks for a fat embolism or signs of that, and signs of compartment syndrome. Remember that swelling can happen inside the cast too. And so that can cause a compartment syndrome because the cast becomes the restricting force, right? So all of these are perfusion issues. So check perfusion distal to the injury. And then, of course, don't forget to address the patient's pain.
Thanks for watching another nursing.com lesson. Click the link below in the description to watch thousands more lessons over on nursing.com. Also, be sure to hit the subscribe and the little bell to make sure you're reminded when new lessons come out. And if you want to just keep watching more lessons, go ahead and click this video over here to continue learning. Like we always say here at nursing.com, happy nursing.